Thank you so much for being here, and so proud that everyone is seeing now what nutrition can do. And we will fight for it because you are what you eat. It's very known. And together with movement and so on, we can take care of our elderly. Just a disclosure that I'm doing more than only the nutrition economics, and am now also a part of the partnership Overweight, in which we see a double burden. It's not only the overweight or obesity, it's also malnourishment during the obesity, so very important. Just to take you with me on the road, what health economics is about, then the cost of illness, cost effectiveness and nutritional economics as a new field. Economics, it's very general. It's the study of the optimal allocation of limited resources for the production of benefit to society. It's very clear that we all want to be healthy. Everyone is in need of more and more money, but there's just one amount of money. So we have to choose. We have to choose what we will do with one bag of the money. You have to make choices, but from which perspective? It's very important to know that before you are going to be able to make some economic calculations. And then you can see cost benefits or other analysis to show you what the return of investment is of the intervention you are really looking at. So health economics means the maximum health gain per euro. It's not that difficult, value for money. How can you then make a decision? Well, there are some basics to do before decision makers can make their choice. You have a cost of illness, budget impact, and you can do economic evaluations. It's all guidelines underneath, so you have to follow the guideline, European international guidelines, to be able to perform high quality analysis. This has been shown already by the former speakers, so everyone knows already that disease-related malnutrition is not good for the quality of life and is also not good for the costs, because it costs a lot of money, and I will show you that later on. First, there's a new publication about the malnutrition risk in the elderly, and it's by the Manual Consortium. It's with a lot of universities, including the Netherlands, and you can see that there's a high malnutrition risk than in more than 20% of the elderly. And the moderate and high is almost 50%. And we know why, because the former speakers already told you why that is. What we did in the Netherlands, it's already some years ago, is that we wanted to convince the government that we have to do something about malnutrition in the Netherlands. And to be able to do so, the first thing you can do is to make a cost of illness analysis. You can show the government or the budget holder in a hospital or wherever how much money it is costing when you are not doing anything about this situation. And you see over here that for the elderly in all the settings, it was costing 1.5 billion a year in the Netherlands. So that was really opening the doors for the government, because it shook them up. It has been done also for other countries, as you can see here, in the UK, Germany, and also the Republic of Ireland. So I would say it's very important to start in your own country to see the prevalence of, well, the people you want to calculate the cost of illness for, and then you can, not that difficult, make a cost of illness, just to show the people who are paying or the people who are not paying, that it's costing a lot of money. This is a study, the cost of malnutrition in elderly, a systematic review, and again you see the same message. Higher medical costs due to readmission, longer stay in hospital, more in need of medical drugs, and so on. So again, also over here, preventive or therapeutic strategies is very important to do so, and I will show you later what it will do. But first, disease-related malnutrition, also the former speakers told what we can do. There are guidelines and we should keep them up to date because we see again and again more interventions that are useful. Early identification, screening, and then you have to manage the person who is in need of the management. We have a management plan for disease-related malnutrition. It's in the guideline, in the Dutch guideline, to fight malnutrition. And we use this because you have to do something, and it's very important that you have to take into account not only the macronutrients, but also the micronutrients. Because when you only add or give more protein, then it does not do what it's supposed to do, what it should do. And therefore, nutrition is really a very important science because everything is doing the things together. And screening without management is also useless. When there is not a plan to take care of the people who are really malnourished, then don't even bother to screen because it's costing. It's costing hours of people who are doing it, and it's useless. So before showing you some results of cost-effectiveness studies, where are we looking for? What is cost-effective and what is not? And that's the cost-effectiveness plan. So it's really about looking at two or more interventions and compare in effectiveness and in costs. Very easy. When it's less costly and more effective, it's saving costs. But the other side, it's not doing anything, so don't bother. And then it's very important this side, because when it's now cost effective and when it's not, and that's all depending on the willingness to pay in the country. Different thresholds in different countries. So in England, there's a threshold for being cost effective of €20,000. So when you are beneath the willingness to pay, the threshold, then it's cost effective. When you are above it, then it's not. And this is how the government and all people who are really taking care of the money, where to spend it on, this can be a game changer. Before we can do cost effectiveness analysis, we have to use the effectiveness data. And we have a lot for the disease-related malnutrition management. And then you come to the economic benefits of all those showed positive outcomes. This was a budget impact, the first one we did in the Netherlands. And over here we saw that people, the elderly, who were treated in the right way, including medical nutrition, is saving money. It's not costing money, it's even saving money. So it was even a cost saving of nearly 13 million euros. Then another economic evaluation has been done in England. And also over here, we saw that there's an incremental cost effectiveness ratio, the ISPOR, of 10 to 12,000 per quali, meaning on the cost effectiveness plane, the threshold is at 20,000 per quality adjusted life year. It is more quality per year. So it's really cost effective. Another one, they were looking for the guideline. The NICE guideline is also a good guideline, and they have looked in the data and they have calculated, okay, what are the costs to implement the guideline and what are the benefits then? As you can see over here, also again, it is very cost effective to implement the guideline from screening until management. And again, we see the same outcome. It is saving costs. You can even make money from doing the right thing and start with screening and manage in an optimal way. And then you can save a lot of money and also then quality of life. We did, again, another cost effectiveness measurement in the elderly persons in the Netherlands. And you can see here, we stated it in another way, for every euro spent on the management of disease-related malnutrition, you gain money. So it's really a moneymaker. A very important thing, and it's really close to my heart because I'm a dietitian by education and also a nutritionist. We cannot do without dietitians. Those are really the professionals trained for at least 4 years. They know the guidelines. They know what to do at what time. So it's very, very important to really work with them. Otherwise, you are going to get perhaps the wrong interventions, and then there is no optimal management, and then those outcomes which you saw will not be there. So again, these malnourished hospital patients were treated by the guidelines, but by the dietitians. So every euro spent, you save again money, including their salary. Another one in New Zealand. Also, again, this was for obesity, cardiovascular disease, diabetes, and malnutrition. Also over there, for the money you are spending, you are getting a lot of money back. And next to the money, also the quality of life of the patients. Everyone is working with pleasure. It's gaining a lot. Another one, and it's a repetition. It's again and again the same outcome. So, the biggest cost is not the intervention and the screening and the management. The biggest cost is not doing anything and leaving the disease-related malnutrition unknown and not acknowledged. So, in 2014, we founded a special interest group within the ISPOR, Nutrition Economics, and we still want to bring the Health Economic Society together with the Nutrition Society. Let's bridge them. Let we really bridge them to have the nutrition economics. There are two fields, and we merged it to one. We already have 2 publications and really starting to let the health economics persons know what we're talking about in the nutrition world. Because it starts with the right terminology. When we're not talking the same language, then we cannot do anything. So the take-home messages. Cost of illness, you can show really that disease-related malnutrition has a lot of additional costs. Optimal nutritional management can save cost, not only be cost-effective, but it can really save costs, money maker. Investing in optimal nutrition next to all the other treatments like movement and so on is very important. It should be standard. Nutrition economics as a new field, we hope that it will be a very, bigger than it is now, so please join. And when you want to do economic performance or economic evaluations, please use the guidelines, because then you only have the high quality analysis, and then you can really change whatever you want to do with nutrition. So thank you so much for your attention.